So we have a talk today from Phoebe about various health economic things, and I'm going to quickly run away and go and buy cake, but I'll be back for the end of the talk. Take it away.
Thanks, Andrew. Today I'm going to talk about health economic modeling in the context of infectious diseases. Okay, so health economics in general is basically just taking techniques from economics and applying it to health-related problems. Kind of does what it says on the tin. More specifically, when it comes to infectious diseases, mostly when people say health economics, they mean cost-effectiveness analysis. It's not necessarily the be-all, end-all. There is other things within health economics, including things like behavioral economics, that sort of thing. So in order to figure out how cost-effective an intervention is, first we need to kind of go back a bit and figure out how beneficial our intervention is. So how can we figure out how bad an outbreak is? We've got these two outbreaks. One of them has slightly fewer cases, but quite a lot of hospitalizations. Another one that's got way more cases but fewer hospitalizations. How do we balance this out? At what point would we rather have more cases or more hospitalizations? So to do this, we can use QALYs, or quality adjusted life years. So this is a measure of the benefit of our intervention. So one QALY is equivalent to 1 year lived in perfect health. So we have this quality of life score, which is used to weight our QALY. So a score of 1 is perfect health, a score of 0 is death, and then pretty much everything else is in the middle somewhere. Although you can get some things which are in the negative, some things that are deemed to be worse than death. And then in order to calculate our QALYs, what we do is we've got a no intervention scenario. So this is maybe someone gets infected at this point, their quality of life score drops, and then maybe they get a bit worse, maybe they get hospitalized, and then at this point they die. And then in the case where we use our intervention, instead they don't get infected, and they kind of live their life out as usual, maybe deteriorate a bit, and then they die at some old age. So our QALYs gained by the intervention, in this case, is the difference in these two areas. So taking a bit of a simpler case, if we just had someone has symptomatic infection, say it lasts a week, 7 days, and then after that they fully recover and they live their life as usual, there are like no onwards impacts, then this is really easy to calculate. We just have to find the difference in our quality of life score. So here I've said some baseline of 0.95, so we end up with a loss of 0.25, and then we have to multiply it by the time spent symptomatic. This is in years, so 7 over 365. And this ends up around 0.005 QALYs. The other thing we have to think about is calculating QALY losses from fatal cases. Here we have, this is the total QALY losses from all of the fatal cases in the outbreak. So this is summed over all of the age groups, and then we have the number of deaths in each age group and the quality adjusted remaining life expectancy. So this is taking into account the fact that sort of your quality of life is expected to kind of decrease as you get older. It's not just your life expectancy. This is obviously summing over all of our age groups, which if you were to apply this to your results from an infectious disease model, obviously you would need your infectious disease model to be age structured. That's not always necessarily the case, although most of the time when health economic analysis was performed, you would make that kind of segregation. It's still possible to calculate these QALY losses from fatal cases. It just requires a bit of thought, because you can't really just take the average quality adjusted life expectancy across the whole population, because diseases can vary a lot in terms of who they predominantly affect. So if you had a predominantly childhood disease, you would have much higher expected quality of life, what am I saying? Sorry, I've got my words messed up. You would have much higher much higher quality-adjusted remaining life expectancies than if the disease predominantly affected older adults. So, quick little example. So, let's say we've got an outbreak that causes 100 asymptomatic cases, 200 symptomatic cases, of which 10 are hospitalized and 2 are fatal. Then we've got our QALY losses, and you can see that the QALY losses from a fatal case are massively higher than any of the others, which is kind of what we'd expect. Always the main priority is preventing fatalities. And then we've also made the assumption that asymptomatic cases come with no QALY losses, which makes sense. Otherwise, there would have to be symptoms going along with that QALY loss. So then calculating this is super easy. So we have 190, so this is 200 minus these 10 hospitalized cases times 0.005, and then 8 times 0.01, and then 2 times 40. So we end up with around 80 QALYs. A quick side note to talk about QALYs versus DALYs. So obviously, this is what I've just introduced. So number of years of survival times by the quality of life score. But you also hear a lot of people talking about DALYs, so disability adjusted life years. So this, instead of being a measure of the benefit of a disease, of an intervention, we're talking about a measure of the burden of the disease on the population. And this is more commonly used in lower and middle income countries, whereas in the UK, we would predominantly just use QALYs. So it is slightly different in terms of how it's calculated, and you can get different results if you use one or the other. But all of the methods that I'm about to talk about can be applied regardless of whether you're using QALYs or DALYs. Okay, so now we have a measure of the benefit of our intervention, and we want to talk about when is it cost effective. So to do that, we need to set a willingness to pay threshold. So this is the amount we'd be willing to pay to gain 1 QALY. So the World Health Organization, they used to advise that a strategy was very cost effective if the willingness to pay was at the GDP per capita, and cost effective when it was at 3 times the GDP per capita. Although this is particularly, again, in lower and middle income countries. In the UK, we use typically a willingness to pay of £20,000, and this is much less than our GDP per capita. So the next thing we have to take into account is costs. So sort of 2 main categories of costs are outbreak costs and our intervention costs. So outbreak costs are the costs we're avoiding by using our intervention, and then the intervention costs are the costs of implementing our intervention. So for both of these, we have direct and indirect costs, and which of these we care about depends on our perspective that we're looking from. So there are kind of 2 main perspectives that you can take. You can either perform your analysis from the perspective of the healthcare system, so for example, from the perspective of the NHS, in which case you would solely be caring about direct costs. So the cost when someone gets ill of being hospitalized, cost of GP appointments, cost of medication, that sort of thing. And then on the interventions cost, it would be cost of vaccine doses, infrastructure costs, that sort of thing. And then on the other hand, you can look more broadly from a societal perspective. So in that case, you would want to take in, I guess, more general costs to the society and to the economy. So that could be costs from time off work after getting infected, or cost to the economy from self-isolation. And this could also include more abstract things like mental health implications of self-isolating, that sort of thing. So now we have all of our pieces and we can put it all together, and we end up with this sort of equation for cost effectiveness. So it's basically just that if the monetary benefit of our QALYs gained is greater than our overall cost, then it's cost effective. So just to continue our example from before, remember we had QALY loss of 81 QALYs. So we can say we have a potential intervention we can do where we vaccinate our whole population of 10,000 people, completely preventing the outbreak. And then our costs, so our outbreak costs would be £1,000 per hospitalised case, and then our intervention costs would be £10 per vaccine dose. You can see this all works out very nicely. This is very easily cost effective. Yeah, because this is much higher than 90,000. However, if we changed our willingness to pay threshold, so this is down to £1,000, so this I think is similar to what they have in the DRC, where their GDP is around £500 per capita. And then in this case, the intervention would no longer be cost effective, assuming that all of the underlying disease model would be the same in that setting. So another thing we can look at when determining if an intervention is cost effective is the threshold intervention cost. So this is the maximum amount of money we'd be willing to pay per unit intervention cost. So for example, per dose of vaccine, and have it still be cost effective. So we can just take our equation from before and rearrange it, and we get that below this value, the intervention is cost effective. So what's the point of doing that? One of the main times that this has been used in the literature is negotiating with suppliers. So often there will be some estimate for how much, let's say, how much the vaccine will cost. And then you can perform this analysis and say, actually, this is the value at which we'd be willing to pay per dose. And this is the point at which the intervention would become cost effective. And it's really powerful because you're literally saying above that point, there's basically no point us even using your vaccine. And there's not much they can do about that. Another kind of interesting way to look at this, is calculating incentives. So for something like self-isolation, where you don't have a specific intervention cost, you could think of this as if you had a threshold intervention cost of £100, then what you'd be saying is you'd be willing to pay someone up to £100 to self-isolate. Or similarly, spend that amount of money doing advertising campaigns, that sort of thing, to encourage them to self-isolate. Another reason it's useful, and this is why I use it in my work, is if the cost per dose is unknown, then this can get rid of an extra parameter with uncertainty. So carrying on with our example, we end up with, at a willingness to pay threshold of £20,000 per QALY, then we'd be willing to pay up to £161 per dose. And then when our willingness to pay threshold was £1,000 per QALY, we'd only be willing to pay up to £9 per dose. Another quick aside to talk about discounting. So this is when you care more about events that are going to happen soon than events that are going to happen a long time in the future. So you can kind of think of this as you're a politician and you want to put in your great new policy that will prevent cases. You'd much rather save 1,000 cases in the next 5 years than 1,000 cases in 50 years when everyone's kind of forgotten about you. It's pretty typical to apply discounting at 3%. So each year that passes, you care about it 3% less. And this is just an example showing this is the total QALYs gained by the intervention. And then this here is the QALYs gained in simulation year Y. So you'd also have to do the same thing with your calculating your costs. Those would also be discounted. We also have to apply discounting when calculating QALY losses from fatal cases. So instead of just summing over all the age classes, calculating deaths and the quality adjusted life expectancy, you now have to sum over the simulation year again. And this DYA is deaths in simulation year Y of people in age class A. So now we have a measure of when an intervention is cost effective. We want to talk about comparing between multiple interventions. How can we know which one is more cost effective? So we have our cost effectiveness plane. We've got QALYs gained versus the comparator strategy along the bottom, and then additional costs versus the comparator strategy on the y-axis. So in this top left-hand corner, it's pretty simple. We're gaining fewer qualies and we're spending more money. So we basically never adopt this strategy. So this strategy is said to be dominated. Similarly, in this bottom right-hand corner, we gain more qualies for less cost. So this strategy dominates the other strategy, and we always adopt it. But then in these kind of two segments, where either we're spending more and getting more for our money, getting more out of it, or we're spending less and gaining fewer qualies, it's a bit more unclear what we have to do. So there are two approaches which are basically the same thing, just rearranged. So we have on the left incremental cost effectiveness ratio. So this is, you calculate the difference in costs between the two strategies over the difference in qualities gained. And then if this is less than or equal to our willingness to pay threshold, then the intervention is more cost effective than the other intervention we're comparing it to. And then on the other hand, we have net monetary benefits, which as you can see, this is literally just the same thing rearranged, where this is the overall monetary gain from the intervention, from going from our comparator intervention to our new intervention. And if this is positive, then we switch to that strategy. So for our, you can plot the incremental cost effectiveness ratios on this cost effectiveness plane. So again, we have qualities against costs. So the incremental cost effectiveness ratio is just the gradient of this line. So you can see in this case, if we say our willingness to pay is £1,000, then we would adopt strategy A over no strategy, but we wouldn't adopt strategy B. On the other hand, if it looks more like this, then we would adopt strategy B. So because this ISA, so the incremental cost effectiveness ratio, is decreasing, we say that this strategy is weakly dominated, because we would just go straight to doing B. Okay, so that was a bit of a quick run through everything you need to know about health economics. Now I'm going to talk about what I actually do. So my PhD project is looking at symptom propagation. So this is when the symptoms an individual experiences depends on the symptoms of the person who infected them. So if you're infected by someone with really severe disease, you'd be more likely to have severe disease yourself. So this is the schematic for my model. Basically, it's defined by two parameters, alpha and nu. So this alpha is sort of the strength of symptom propagation. So with probability alpha, you just copy the symptom severity of the person who infected you. And then with probability 1 minus alpha, you revert to this sort of underlying baseline probability of severe disease, nu. So if alpha is 0, then this would just be that you develop severe disease with probability nu. So we're going to consider two possible vaccines. We have an infection-blocking vaccine, which is the efficacy of just not being infected, so they stay susceptible. And then we have a symptom-attenuating vaccine, where at each transmission event, the vaccinated individual has a probability eta of developing mild disease instead of severe disease. So they get their symptom severity sort of downgraded. A couple of assumptions. We're going to assume 70% efficacy, so a severity, 90% uptake, and then we're going to assume that we don't know alpha, so we don't know our strength of symptom propagation. And we're going to look at alpha equals 0, so no symptom propagation, and then alpha equals half, and alpha equals 0.8. So for our two intervention types, we can look at the qualities gained by the intervention. So you can see for no symptom propagation and alpha equals a half, the infection blocking vaccine is more effective at gains more qualities than the symptom attenuating vaccine, although these two are very similar. But for high alpha, alpha equals 0.8, we find that symptom attenuating gains more QALYs. We can also kind of shift this to looking at our threshold intervention costs, although they're about the same because we've assumed that they have the same uptake. In this case, if our vaccine cost £60 per dose, our IB vaccine would be cost effective, but the symptom attenuating one wouldn't be cost effective. And also, if it was below this level, so say it costs £30, then the IB vaccine would be more cost effective still than symptom attenuating, but they would still both be cost effective. So then now that we've got an idea of which of the two vaccine types is more effective for each value of alpha, we can kind of expand this to look at more questions. So maybe we want to look at which uptake is better. So this is looking at 90% uptake, which is quite high. So maybe we want to look at 50% uptake instead. Can we get away with 50% uptake? This is with 50% uptake added in, so these dashed bars, 50%, and the solid bars are 90%. So you can see in all cases, the threshold intervention cost for 50% is higher than the 90% one. And this is just because it's basically diminishing returns. The first couple of vaccines that you give out are always going to be proportionally more effective than the later ones you give out, because you have the additional effect of those people you vaccinated not infecting other people. So those other people are still kind of protected even though they're not vaccinated. We can also see that in the 50% uptake case, we kind of have a change in which one has a higher threshold intervention cost. So now, for all of them, this symptom attenuating vaccine is more cost effective. So we can look across uptake values, and we basically end up with these plots where at low uptake, symptom attenuating is always more cost effective, and then we hit some uptake value above which infection blocking becomes more cost effective. So another big question to answer in health economic modeling is how can we deal with uncertainty? Obviously, there's in basically any type of infectious disease modeling, there's always lots and lots of uncertainty within our parameters, and then adding on this kind of health economic modeling adds more uncertainty in terms of costs of the intervention, uptake, efficacy, and other factors. Two ways to deal with uncertainty than this. We can either basically run a bunch of simulations and then determine which of our strategies, so the three options in this case being no strategy, or no intervention, infection blocking, and symptom attenuating, which of those has the highest probability of being optimal. So across all of our simulations, is the optimal strategy most often. And this is a very risk-averse strategy. More commonly, we use mean net monetary benefits. So on average, across all the simulations, which of our three intervention strategies does the best? So then we end up with something that looks kind of like this. We have on the bottom, no intervention, infection blocking, symptom attenuating, and we'll have some probability that no intervention is optimal because I chose this cost per dose to be 100, so high enough. If this was low, if this was say £20, then this would also be 0. And then we have our mean net monetary benefit. This is versus the no intervention strategy. So this will always be 0, but these two can be negative. So they can still be worse on average than the no intervention. Typically, these two things will give you the same results. So obviously, in this case, symptom attenuating has the highest probability of being optimal and also gives the highest average net monetary benefits. But that is not always the case. And then you kind of have to go back to whether you'd rather be more risk-averse or risk-neutral. So other things to think about in health economic modeling. As I said, there's lots of ways that you can include uncertainty. So in costs, intervention effectiveness, and uptakes. There's also, as I said earlier, lots of facets to health economics. particularly including behavioral factors, which can be implemented both in the disease model, but also in your intervention implementation. And then finally, comparing between the two perspectives of the healthcare system and the societal perspective. Thank you very much. Does anyone have any questions?